Hello, my name is Michael Mack, and we're here at Birmingham in the UK at the Society for Cardiothoracic Surgery in Great Britain and Ireland. Today, we have two distinguished cardiac surgeons. On my immediate left is Volkmar Falk, who is the chief at the Heart Center in Berlin, and Joe Bavaria, who is at the University of Pennsylvania and is currently the president of Society of Thoracic Surgeons. Today we're going to talk about the current challenges and the future of cardiac surgery, and I can think of no two more qualified individuals than Volkmar and Joe to address this. So let me start by asking, what in the last couple years do you view as the most impactful accomplishments in cardiac surgery? So before we go to the future, just kind of tell us what you think has happened in the last couple years that is most significant to our field. Volkmar?
Well, to my view, the best thing that we did, and at the same time, one thing that also threatens us in some ways, is the development of TBar. As a matter of fact, it was surgeons to really get going in this, and we have helped to get it started. But now what we see is a development which threatens our profession to some degree. But clearly, the advancement of transcatheter techniques has impacted our profession more than anything else before.
And so a big part of the introduction of TBar was the heart team. Do you see the heart team staying together, or is there going to be tension on that going forward?
I think the concept has been widely adopted. It's also laid down in all the guidelines. And reasonable people understand that this is probably the best way to move forward. On the other hand, what I see and what I experienced in Switzerland and also in Germany, that a large group of cardiologists question the concept, thinking that since they can do diagnosis, they can do also the therapy, we are more or less bystanders. And right now it's quite hard to keep that concept going. I'm pretty sure we will have it in the upcoming guideline in 2017 for ESC and EX. I'm a strong believer in the concept, but it is constantly challenged.
So Joe, you were instrumental in introducing TBar into the United States. What parallels do you see happening in the U.S., and do you see the heart team staying together in the U.S.?
Well, first of all, I agree with Volkmar that one of the good things is regarding cardiac surgery and cardiology to a certain extent is that in the U.S. we did complete very robust clinical randomized trials in TBar, and this is a very important development and can be viewed positively in many respects, certainly for our patients. I do agree with Volkmar that the heart team is something that is under a little bit of stress, a little bit of tension. I do believe that in the future that may increase. Presently, it's reasonably robust, although I think it's falling down in certain areas. So I think that we have to be prepared for this possibility. I agree with Volkmar that in the U.S. anyway, we will probably maintain a certain amount of collegiality and at the governmental and recommendation and guideline levels with the various AHA, ACC proclamations and the STS guidelines, that the heart team will survive, at least from a recommendation standpoint and a suggestion standpoint. Now, whether that happens in reality can be debated, and I think there will be a little bit of an erosion. We'll have to see. It's interesting that transcatheter mitral valve may be actually a catalyst to keep it together because that is such a new technology, and pretty obviously at this stage certainly will require probably not only a heart team with cardiac surgeons, but actually a leadership role with cardiac surgeons. At this stage, it's a more complicated operation, a more complicated set of circumstances.
So before we get to the mitral space, which we'll get to in just a minute, let me kind of ask you about TBar. You were very instrumental in the introduction of TBar in the U.S., in which a large proportion of open procedures converted over a decade to endovascular procedures. What are the parallels and what are the differences between TBar and TBar?
Well, there's quite a few parallels in the sense that we have to to work with another specialty in a lot of respects with vascular surgery, being in the U.S. anyway, in North America being mostly vascular surgery, maybe interventional radiology to a more extent in Europe. But TBar, there's a lot of opportunities in TBar with the cardiac surgical specialty, to be honest with you. In the past, over the last 20 years, we started off with endovascular aortic repair as an abdominal issue, and then it became a little bit more into the thoracic space for the descending aorta. And so most of the resources were directed in that area. However, if you look at the resources that are being developed and placed by industry in general, 80 to 90% of all resources are going to be placed into the proximal thoracic aorta at this point. So this is a space that we should own, that we should be a part of, I think that more and more cardiovascular surgeons, especially maybe in North America, are being trained in advanced wire skills in TBar, and I think that this space will be quite successful for us, to be honest with you.
So you're talking about the treatment of acute type A dissections,
so we're talking
by
about
an endovascular approach,
right,
mainly transapical?
No, we're talking about the treatment of the arch, arch into the ascending aorta, treatment of the ascending aorta directly. And that, you're right, that would be mostly a type A dissection to begin with. Basically, the treatment paradigm is going to be everything from the valve plane to the ligament. Most of these trials, and I always believe, like you have always believed, that culture is set at the trial level. Culture is set at the trial level, and so we're working very hard to make sure that at the trial level, that cardiac surgery is really, really heavily involved with these trials. So I'm optimistic that of all of the stressors in cardiac surgery, when you talk about TAVI and TBAR in the earlier days, this will be probably the one that's most representative from the cardiac surgical side. So, but to answer your question directly, it's going to be a big part of what we do as a specialty over the next 10 or 15 years. It's kind of the third big paradigm shift after EVAR for abdominal aortic aneurysms, TBAR for descending thoracic pathologies, and now the proximal thoracic aorta. I'd also like to answer your question initially, which was what are the kind of the big successful things. I think on the LVAD side of things, for the specialty, we've done very well. We've had some excellent trials coming out. There's going to be expanded and better treatment paradigms regarding devices for heart failure. I think this is a huge and exciting part of cardiac surgery. I think the whole minimally invasive revolution is onward and going, and it's going to be a very key part of what we do. Valvular reparative surgery is getting better and better. It is now extending over to the aortic valve as well with improved outcomes. So there are a lot of areas in cardiovascular surgery. ECMO, the entire extracorporeal circulation aspect of what we do as cardiovascular surgeons, and even thoracic surgery is booming. And cardiac surgeons will generally, since they obviously have the experience with extracorporeal techniques and management of complex circulation is going to be the forefront of that. So there are a lot of areas which are quite promising. I have to from the standpoint of organized cardiac surgery, which would be the British Society, the German Society, EACTS, STS, and the American societies, we have to also recognize this. And right now, for example, on our database side and on our reporting side, we're really reporting kind of old style operations, which are cabbages and valve surgery. We need to start having better reporting and better indices and better databases for LVADs, for ECMO, for minimally invasive mitral valve surgery and reparative valve surgery. So we need to kind of expand into the areas that are our future.
So Volkmar, you mentioned the mitral space, and we see that transcatheter therapies now, mainly MitraClip, but a number of other technologies in the pipeline are addressing mitral regurgitation, mitral annular calcification, et cetera. How do you see the mitral space sorting out?
I think it's rapidly moving. What we see now is just the beginning. In a number of centers, the MitraClip is already the default approach for treatment of functional MR. And from my personal experience in the greater Berlin area, I see that more and more patients with degenerative disease get treated. In theory, we should also have the heart team go in there, but as a matter of fact, in terms of the risk adjustment, the risk assessment, I have the impression that people consider the MitraClip safe also in that domain. Now, is that a good development? I'm not sure, but I would like to mention one thing that I consider also a great advantage and a great movement is that we have now a number of randomized trials in the field. For decades, cardiac surgeons were too lazy to run randomized trials, and now thanks to the CTS network, we have clinical trials that are robust. Unfortunately, not always to our favor,
Right.
but so it is. And I think we need to continue that. Some of the trials, especially in the mitral space, should have done in the 80s. For example, we still lack a randomized trial for degenerative mitral valve treatment. We don't have one for P2 prolapse against mitral valve replacement. But the danger is that results from functional MR are extrapolated into the degenerative field. And yes, if we see that development continuing with percutaneous mitral valve replacements, we will have a randomized trial at some point for degenerative mitral valve disease. And so despite the excellent outcomes we have with repair and minimally invasive repair, this will be challenged also with the advent of a true percutaneous approach.
So we know that there was a randomized trial of MitraClip versus degenerative disease in high-risk patients. And the interpretation of that trial all depends upon who's interpreting it, but I think generally it's felt that surgery won. Are we at the stage that we need to do an intermediate risk trial of MitraClip versus surgery?
Well, the problem for me would be I would not be willing to randomize patients that I can do almost perfect repair to a clip therapy for DMR. I mean, and most people I think will feel the same way. On the other hand, in the absence of this trial, the best that we can say is evidence-based, right? So I make a claim which may have no grounds. So if you ask me as a scientist, the answer is yes, we need to do that trial at some point. And we probably, since we see that mitral valve is treated in earlier stages in asymptomatic patients, that's where we're moving with the excellent repair rates that we have, we probably have to expand even to low-risk patients.
So we had a blue sky meeting at the NIH in the United States last week in which we brainstormed what are the next most important trials to do in cardiac surgery through the CTSN trial network. What do you both feel are the most important questions that need to be answered in cardiac surgery that can be done in a randomized trial format?
Well, that's a good question. I do believe that the whole functional MR space should probably be examined. I'm not sure I know exactly how a randomized trial should be designed, but I don't think we actually know enough data on MitraClip versus reparative surgery versus medical management and the various subgroup analyses that could come along from that. Frankly, even though we have some trials regarding coronary bypass surgery and PCI, we have some interesting developments going on in that whole space that may be appropriate to do a randomized trial on, like bilateral mammary arteries in patients under the age of 65 or 70 versus PCI, looking at a longer range endpoint. That might be difficult in a surgery network trial, but we have some prospective randomizers, some big data, New England Journal of Paper Medicine type of trials, but I'm not so sure it's been answered. The last real prospective randomized trial in the U.S. anyway was way back when. The Europeans.
How about neurologic outcomes after circulatory arrest for arch disease? Is that question answered?
The problem with that is that what's your comparative group? I suppose you could look at different types of circulation management protocols. I'm giving a talk at this meeting right now in a couple of minutes, and I think that for the most part, both in the U.S. and Europe, or North America and Europe, the great majority of surgeons are using integrated cerebral perfusion techniques of various types for high-end arch cases. So that question, although has never been prospectively randomized trial, is by consensus has become very much a force, and you may start having some equipoise issues with your trial.
So Volkmar, what do you feel are the most compelling questions that need to be answered in clinical
I think,
trials?
yeah, one of the most important questions is where do we stand with LVAD therapy in the treatment of heart failure? Right now, the patient is going a downward spiral. He's getting medical treatment, then CRT, then mitral clip, and in the very end, people start thinking about LVAD therapy. Sometimes when it is too late, right heart failure has already occurred. So we're actually conducting a trial, an early LVAD trial in Germany right now. It just has started enrollment, but I think that should be done on a larger scale to find out what is exactly the role of LVAD, when should it be implanted. And I think we should do a randomized trial with one arm with an early LVAD implantation, and maybe in some patients even thinking about doing it before a CRT implantation.
So I'd like to ask you a question on the LVAD thing. Do you think that the devices are, the new third generation LVAD devices are good enough for us to start thinking about this kind of trial?
So I think they are, although as you know, we've had a bump in the road now with some device thrombosis that was unexpected, but I think it's close to getting to the stage now that they can be placed by minimally invasive approaches, much less bulky. I think at the end of the day, what's going to accelerate the whole field is when we get to transcutaneous transmission of energy.
So the other thing I thought that might be, or thinking, and I'd like your opinion on this as well, is that there is a difference between a RCT or a regular trial that's going for a PMA submission, in other words, something that a company's doing
Right.
Through the FDA or through the European Union, compared to a national run randomized clinical trial, which might have a lot less bias associated with it. So do you think at the NIH level or even at the German national level, is there a room for another trial, a randomized trial in TAVI versus surgery for intermediate risk, for example?
So I think the answer is yes, and indeed Volkmar is leading a collaboration of German centers working with the CTSN network in the United States, and I think that opens up a whole new platform for doing randomized trials going forward.
And adding to this, maybe we're doing this right now. We will start enrolling a randomized trial, TAVI versus surgical AVR, including 1,000 patients, the so-called DEDICATE trial, and that will start enrolling anytime, hopefully in summer. And it's exactly answering the question. It's an all-comer trial and all valve types are involved, so we don't make any suggestion on what type of valve you should be using. And it will include patients age 65 or older. So it's already an intermediate risk trial.
So we're almost out of time here, but I'd like to ask you both a couple burning questions here at the end. First of all, we haven't talked about coronary artery bypass surgery at all, and it still is the bread and butter of cardiac surgery. The decline, at least in the US, has plateaued, probably due to the results of randomized trials, but where do you see coronary bypass going forward? Volkmar?
Well, there's a couple interesting innovations, again, coming from cardiology. First of all, they do now plug sealing, OCT based. So the whole concept of what you actually treat in the coronary tree is changing rapidly. With more information on plaque morphology, I think the idea is no longer to just go for the most narrow space, but for the most vulnerable plaque. At the same time, we have this not yet completed development of bioabsorbable stents, and the combination of the two, better understanding of where to place a stent in combination with that it's an absorbable stent, in the end may completely change the stenting business. And it's already affecting our view on what is double or triple vessel disease. Now, we base our decision on treating patients with coronary bypass surgery versus stenting on the syntax score, but with better understanding on the morphology of plaques, and we will probably see a change in this pattern, which will have immediate impact on the number of cases we do.
Joe, what do you see happening with coronary artery bypass
Well,
surgery?
we, like you, have seen a plateau in our coronary bypass surgery, maybe even a slight uptick at a certain number of the hospitals. So this has been a race, so to speak, this decline. But we haven't really seen that much of an increase, to be honest with you. But it has plateaued out. I see a possible increase in this. I would love to see some trials I think that the use of bilateral arterial or ubiquitous use of at least two arterial conduits would be really very appropriate. And I think we may see some cardiology buy into this. It's interesting that while at the same time there's been either a plateau or a very slight increase in the number of coronary bypass surgery operations, at least at our institution, there's been a decline in the number of PCI. And that's probably, as you said, a result of some of the medical management versus PCI, prospective randomized trials that are coming out of the cardiology literature. But I'm cautiously optimistic, but we do need to have a little bit of a change in culture.
So last question for both of you. Both of you are senior leadership individuals in our field. If you were starting your training all over again tomorrow, what would you do?
Well, I would do the same thing. I'm passionate about cardiac surgery, so it's a fun job. It's interesting.
But are there any skill sets you would learn that you didn't?
But I would try to get interventional skills from the start, and I think that is how we have to change our education programs. I mean, we have to have those skills, but I would still love to be a cardiac surgeon.
Joe?
Totally agree. I tried to do this myself personally. I do my wire operations, so to speak, TAVIs and TBARs 1 day a week, every week, and open operations. So that needs to be part of what we do. I would think that, and I would like to be a cardiac surgeon as well. I'm a positive about our specialty. I feel that if I was giving some advice to a young surgeon coming up right now, I would say we have a vibrant specialty. Heart failure transplant, VADs, ECMO is a huge part of our business and is going to grow. Reparative valve surgery is another area that you need to be involved with. Endocardiac, endovascular skill sets and surgery is going to be huge. And and the aorta is also a very, very important business. So I would say specialize in one of those four things or a couple of those four things.
Okay, great. So thank you both very much. I know I found this incredibly interesting and exciting, and we hope that the viewers do also. Thank you both very much.
Thank you, Mike.
Thank you, Michael.